Welcome everybody to this webinar talking about a new technology, 3D-Shaper, and how it can be applied in clinical research, state-of-the-art and potential applications. My name is Professor David Kendler. I'm from Vancouver, Canada, the University of British Columbia, and I will be the moderator and chairman of the presentation. And I'm joined by two speakers, Ludovic Humbert and Renaud Winzenrieth, who are with 3D-Shaper Medical. Just to introduce them briefly, Ludo is a scientist and entrepreneur with 15 years experience in computational imaging, and he holds a PhD in biomechanics from Paris Tech in France. And he's the head of the musculoskeletal unit at Galgo Medical, which was founded in 2013 in Barcelona. Renaud Winzenrieth joined Galgo Medical in 2016 after a career with Medimaps and a track record developing trabecular bone score, or TBS, which should be well known to many of you. Renaud has a PhD in biomedical engineering from the University of Technology in France, and an engineering degree in control and computer programming. So they will be our speakers today. If you can advance to the next slide. Our agenda, to start with, I'll make some remarks about why we're interested in looking at 3D-Shaper software and hip imaging. Certainly hip fractures are the highest cost and morbidity fractures in osteoporosis care, and we know that finite element analysis from CT scans of the proximal femur are more effective than aerial DEXA, aerial BMD from DEXA, in predicting hip fracture risk. However, CT scans are expensive and there's a high radiation associated. We also know that there's a recent initiative headed by Dennis Black called FNIH to develop changes in hip aerial bone density as being a surrogate for anti-fracture efficacy, perhaps in the future precluding the need for fracture endpoint studies. So the focus on hip bone density has certainly become more acute with the FNIH initiative. We also know from a variety of studies that the distribution of bone density in the proximal femur may have great import in predicting fracture and in predicting anti-fracture efficacy of different therapies, because the different therapies we have may affect cortical and trabecular bone compartments in a different manner, and therapies that have a greater cortical bone effect may have greater efficacy in preventing non-vertebral fractures. We know that modeling technologies to extrapolate two-dimensional aerial DEXA scans into three-dimensional models with finite element analysis have been shown to add to the fracture predictive value of aerial DEXA, even when adjusted for multiple risks. And today we will hear about the 3D-Shaper technology, which is one of the leading technologies creating a three-dimensional model of the proximal femur, utilizing information from aerial bone density DXA scans that allow the evaluation of series of patients between time points in the past. So that's a little bit of the focus that we have these days on hip imaging. And I will turn over now to Dr. Humbert, who will give us the underlying technology for the 3D-Shaper software. Ludo?
Okay, thank you very much, David, for this very interesting introduction. Good morning and or good afternoon to everybody. I will start I will start with a few words about our company, 3D-Shaper Medical. We're based in Barcelona, in Spain, and we develop advanced analysis of medical images applied to musculoskeletal diseases. So, sorry for that. Okay, so osteoporosis is a very common disease So we have 1 of 3 women and 1 of 5 men that will at some point have a fracture because of osteoporosis. So in clinical practices, physicians, they use DEXA to measure the bone density. So DEXA is a low economic cost and a low radiation dose device. But the diagnosis that you can make from these 2D projections of the bone density is limited. So for an advanced analysis of your bone, a 3D analysis of the bone, physicians, they could use computed tomography, CT. However, CT is expensive and the radiation dose for the patient is high. So CT scan is actually not used in clinical practices for the diagnosis of osteoporosis. So let's say that in an ideal world, physicians, they would like to have the benefits of both medical imaging modalities, and that's what we're trying to bring with 3D-Shaper, because we've developed a software that can provide 3D analysis of the bone from 2D DEXA images. So how do we do that? We use a database of CT scans of a population, and we created a statistical model that incorporates the main variations in terms of the shape and the bone density that we observe in this population. And then when we have the DEXA scan of the patient, what we're going to do is that we are going to register this statistical model onto the image of the patient. So here what you see is the mean statistical model of the patient. And what we are going to do is that we are going to change the pose, the shape, and the density of this model so that its projection that you can see in this region of interest, so that its projection is the same as the DEXA scan of the patient. So you will see it in this video. So you see that we adjust the pose, the shape and density, and that the projection gets better in terms of similarity compared to the 2D DEXA scan of the patient. So at the end of the process, what you obtain is a personalized CT-like model of the femur of the patient. Then, in a second step, we will segment the cortex and measure the cortical thickness and density. And we will measure the cortical surface BMD, which is actually the multiplication of the cortical density and the cortical thickness. And these measurements provide an estimate of the strength of the cortical bone. So we integrated those methods in a software, 3D-Shaper, that can be used in clinical practices. So here for clinical practices, we wanted to make it easy so that we provide only 2 measurements, one for the cortical bone and one for the trabecular bone. So the cortical surface density and the trabecular volumetric density at the total femur region of interest. We have age-related reference data. The workflow is automated, so it takes 1.5 minutes to process one DEXA scan. We output dedicated reports, and the software is compatible with most Hologic NG scanners using our standalone solution, and is compatible also with DMS imaging scanners as an integrated solution. So here it means that our software is integrated in DMS software solution, so the solution that controls their DEXA scanners. So our software can be used also in clinical research, and that's the main, which is the main purpose of the webinar today. So here in clinical research, we output additional measurements, the volumetric BMD, the bone mineral content, the volume for the integral trabecular and cortical bone, at the neck, the shaft, and the trochanter. In addition to the cortical surface BMD, we also provide measurement of the cortical thickness and density. We also output hip structural measurements, cross-sectional area, cross-sectional moment of inertia, section modulus, and buckling ratio. We can analyze retrospective DEXA scans and do it for multiple scans. So this is typically what a clinician would do if he wants to do a clinical study. So he would load all his DEXA scans to our software, and our software will analyze them all in one batch. So we also provide services for data analysis, where we can process your DEXA scans, and we can also analyze longitudinal changes or changes between groups in a population. So Renaud will give you more details on this later on, but basically what you can see, for example, in those images are average changes after 2 years of denosumab that were measured in the population. And finally, we have, if I can go back to the previous slide, we have another way also to show results of a clinical study, which is basically an app that use an augmented reality tools. So here, basically, you would have a tablet with the app installed, and with the tablet, you would see the environment where you are, and then you can position the femur where you want, wherever you want in the environment, and then you can see the results of your clinical study on this femur. So, for example, in this study you see, in this study you see changes after 2 years of teriparatide. I cannot run the video again, but basically you see the femur and you can see the slices inside, and you can see the changes in the trabecular bone and the cortical bone inside, with the femur here in the environment. So this is basically a marketing tool for the moment, but that's a nice way in a conference, for example, to show the results of your study. We validated the accuracy of 3D-Shaper measurements against CT in this study. Here you see the results we got for 3 subjects. Here you can see the cortical thickness distribution computed by 3D-Shaper and computing using CT scans for those 3 patients. So what you see is that the pattern is similar for those 3 cases. And then here you see a comparison of a frontal slice, 3D-Shaper at the left and QCT at the right for those 3 patients. So here what you see also is that the images are similar. Then when we computed the accuracy for the whole cohort of this study, 157 subjects, we found correlation coefficient above 0.9 for the 3 main 3D-Shaper measurements, which are the cortical surface BMD, the trabecular volumetric BMD, and the integral volumetric BMD. We have new applications that we've been developing. The first one is 3D-Shaper strength. So basically here the idea is to start is to use the 3D-Shaper algorithm, so to start from a DEXA image, and then using the 3D-Shaper output, QCT-like output, we can build a mesh, a volumetric mesh, and then simulate a load on this mesh and use finite element analysis to compute the strength of the femur. And in particular, we can compute the strength of the cortical bone and the strength of the trabecular bone. So here in a preliminary study, we reported that the strength of the trabecular bone was improving the discrimination between cases with fracture at the neck and controls. And we are also developing a very similar application at the spine, 3D-Shaper spine. Here the IV is basically the same as what we've been doing for the femur, to have a statistical model of the shape and density, L1 to L4, and then register this model onto the AP DEXA scan of the patient. Okay, this is what you can see here in this video. And then at the end of the process, you would get a QCT-like model of the lumbar spine of the patient. So here, also in a preliminary study, we found that the trabecular density in the vertebral body was improving the discrimination between patient with and without fracture at the lumbar spine compared to ABMD. Okay, so this is what I wanted to say for the moment, and I will give the floor to Renaud, who will talk about the use of 3D-Shaper in clinical research.
Good morning, good afternoon, good evening to everybody. So as Ludovic told you before, using our DEXA-based 3D modeling approach, we can generate a personalized 3D QCT-like model from a femur, from a single DXA acquisition, and this approach is used for one patient. We can do it for multiple patients and output the results of all these patients. But okay. However, when we're talking about clinical studies, we have to manage a group or groups of patients and not single individuals. To do that, we have developed a pipeline that take this 3D model from individuals to generate an average model of the group. And this is a post-hoc analysis, which is not included into the 3D-Shaper software that you can buy. From there, it is possible to compare two groups. This is typically the case when you perform a case control study, and for instance, if you want to compare subjects with and without fracture, or if you want to follow the evolution of a group or groups in the case of a treatment. With this capability, it is therefore possible to compare groups generating the 3D distribution of the changes between these groups, is the case of the image you have in the top right, or to generate slices inside this average model of difference that you can see in the left panel. But you can also map any other statistical parameter that you can see, for instance, in the panel above, which is the 3D distribution of the area under the curve in the case of a fracture discrimination study. Based on this approach, several clinical studies have been performed and presented, covering different fields, such as the association with the fracture, treatment follow-up, secondary osteoporosis, or the effect of the training. I will focus the rest of my presentation only on the association with the fracture and the osteoporotic drug treatment monitoring. Regarding the association with the fracture, to date we have done 8 studies, and among these studies, 2 are prediction studies. Regarding the fracture discrimination ability, I will present you 2 studies on hip fracture discrimination from the same center, which is in Barcelona. In these 2 studies, we have included men and women only women for the first one and men and women in the second one. We have subject with hip fracture, and we have age-matched control group in both studies. And for the second studies, we have a fracture at the neck only. In both studies, what we have observed is that the trabecular volumetric BMD and as well as the cortical surface BMD are associated with the presence of the osteoporotic fracture, considering the total hip region of interest. And in both studies, we have observed that the trabecular volumetric density exhibited the highest discrimination capability, higher than the areal BMD, but without reaching a significant increase. In the second study, we have performed a local analysis, and what we have observed is that we have found that the superior neck region was found to be the region with the highest discrimination capability, and in this case, the capability is significantly higher than the one you can obtain with the standard areal BMD region. And to illustrate that, you can see here the local mapping of the area under the curve, the values for each voxels in the proximal femur. You can see clearly that the superior part of the neck is an interesting region to consider when talking about neck fracture discrimination, or to evaluate the risk for neck fracture. And this region we have observed in this study is consistent with the regions obtained from the biomechanical experiment. Regarding the fracture prediction, the first study that has been done has investigated the capability of our 3D measurement to predict the fracture. And the study was done in Geneva by the Dr. Beaver and are focused on the prediction of a major osteoporotic fracture. The study cohort is the Jericho cohort that involved roughly 800 postmenopausal women with a mean age at 65 years old at baseline and an average follow-up of 6 years. And during this follow-up, 100 women sustained a low energy fracture, and among them, 44 sustained a major osteoporotic fracture. The main results of this study is that the trabecular volumetric BMD parameter predict the major osteoporotic fracture, as well as areal BMD, considering the neck region of interest, but add an higher prediction capability, considering the total hip region of interest, but without significant improvement of the predictions when compared to areal BMD. And in this study, the cortical volumetric density was not associated with the incidence of major osteoporotic fracture. Recently, another study has been done regarding the prediction of the fracture, and it was done in the Kindai University by the professor Masayuki Iki. And this study focused only on hip fracture prediction, and it's in women. The study cohort is the GPOS cohort that involved 1,386 women with a mean age ranging from 40 to 79 years old at baseline and a follow-up of 20 years. And during the follow-up, 68 women sustained a hip fracture. Hip scan were analyzed using the 3D-Shaper software. And we also, in this case, computed the hip strength analysis parameter. As expected, the areal BMD at both total hip or femoral neck predict the hip fracture, even after adjustment for age. When we have performed the 3D analysis, what we have observed again is that the trabecular volumetric BMD and the cortical SBMD predict the incident fracture, considering the total hip and the intertrochanteric regions. And at the femoral neck regions, what we have observed is that the trabecular volumetric density predicts the fracture, and its association with the incident fracture is significantly higher when compared to areal BMD, even after adjustment for age. We also observed that this, the significativity of these 3D parameters remain even after adjustment for age, BMI, and areal BMD. 3D HSA parameters at femoral neck and intercroteric regions also predict the fracture even after adjustment for the different parameters, that includes areal BMD. Regarding treatment monitoring, we have also done 8 studies on different treatments, and I will present you 2 of them. And this study cover a wide range of treatment that impact bone metabolism. So the first study I want to show you is one comparing the effect of bisphosphonates, denosumab, and teriparatide in postmenopausal women. This is a summary of the results obtained after 24 months of treatment. And as expected, the DXA measurements, I mean the areal BMD, show an increase for all treatment groups in all region of interest, I mean spine and total femur. Under alendronate, you can see that the areal BMD increases is linked to an increase of the trabecular density. While under denosumab and teriparatide, you can see this huge increase of the trabecular compartment. You can see also that under alendronate, the increase at the cortical level, this is the cortical surface BMD, the combined parameter, and this increase of this combined parameter is driven by an increase of the density without modification of the thickness. While under denosumab, the huge increase of the cortical compartment is linked to an increase of the density coupled with an increase of the thickness. Which is really interesting is that when you go to teriparatide, what you can see is that considering this combined parameter, we see almost no changes. But this no changes is a link to an increase of the thickness concomitant to a small decrease of the cortical volumetric density. Here you can see the 3D mapping of these cortical parameters for denosumab and teriparatide. The first line is the cortical surface BMD, the combined parameter. And here you have the distribution of the density and the distribution of the thickness. Increases are in blue green and decreases are in yellow red. You can see that under denosumab you have this homogeneous distribution of the increase of the density and a localized increase of the thickness, which is almost similar to the one you can observe on the teriparatide. While on the teriparatide you see this almost no changes in terms of combined parameter, and this a small decrease, but again, which is homogeneously distributed over the proximal femur in terms of cortical density. As I told you before, we can generate slices as we have a 3D model. So here you have mid-coronal slices, and increases are reported in blue and decreases in red colors. You can see that in both denosumab and teriparatide, you can see this massive increase inside the trabecular compartment. And you can see also the differential effect between the two molecules considering the density changes in the cortical shell. Here is you have this increase, and you can see the decrease inside the cortical shell under teriparatide. Another interesting result came from the analysis of the active trial. This is really new and presented only this year, sorry. And this study has been done in collaboration with Radius Health. We retrospectively analyzed a subset of the active trial, which represents 1/3 of the entire cohort. We have included 250 subjects per arm, and this inclusion was random, and we considering study site and patient ethnicity, and we have analyzed hip DEXA acquisition at baseline, month 6 and month 18. In the phase 3 active trial, it has been shown that a significant increase in terms of areal BMD at the hip in postmenopausal women, significantly higher than the one observed on the teriparatide at both month 6 and 18. And as you can see in our subset, the results obtained are quite similar in terms of behavior and amplitudes that the one observed for the entire cohort. As you can see here, the trabecular volumetric density and the cortical thickness changes at month 18 here in both abaloparatide and teriparatide are really huge and similar in amplitudes with an increase of +9%. And for the cortical thickness, we have an increase of +1.5%. And these changes we observed on the teriparatide and abaloparatide at month 6 and 18 were significantly higher than those observed in the placebo group. But interestingly, the interesting part is the cortical volumetric density changes, because at month 18, what we have observed is that a significant higher increase in the abaloparatide when compared to teriparatide, and the right panel here, you can see this 3D mapping of this parameter, and you can see this homogeneously distributed increase over the proximal femur on the abaloparatide, while on the teriparatide you can see this. You can see a small region that exhibited increases. What we have done then is that to further investigate the effect of both molecules, we have generated slices inside the 3D models. And in these slices, the increases are in blue-green and the decreases are in yellow-red. And what we have observed is that inside the cortical shell, we have observed decreases in terms of density, which are more marked in the regions where the cortex are thicker. And this under both abaloparatide and teriparatide. You can see that it's the red arrow. You can see here and here under teriparatide, and here, for instance, in the shaft, or here under abaloparatide. And these changes observed, interestingly, disappeared. The decrease disappeared under abaloparatide at month 18, while remain under teriparatide at month 18. Okay, so what we have done next is to investigate only these regions that exhibited decreases. So to do that, we have done a dedicated analysis. And what you can see is that at month 6, you can see that decreases occur in the same regions on the both abaloparatide, and it's here, abaloparatide and teriparatide groups. However, these decreases are more pronounced under teriparatide than under abaloparatide, characterized by a mean decrease of minus 2.8 milligram per centimeter cube, while only a decrease of minus 1.9 milligram per centimeter cube was observed under abaloparatide. We have also observed that these, in terms of volume of decreasing voxels, a volume higher under teriparatide than under abaloparatide. But more interestingly, that you can see that here is that after 18 months of treatment, you can see that the decreasing regions have almost disappeared under abaloparatide and represent only 0.15% of the total volume of the proximal femur versus roughly 4.7% at month 6. While at the same time, you see that decreasing regions almost maintain in volume under teriparatide, but increase in average value from minus 3.9, with a decrease of minus 3.9 at month 18 versus a decrease of 2.8 milligram per centimeter cube at month 6. Okay, now I will show you, this is like image. And as Ludovic showed you before, we can generate also a video, because we can move around the femur. So in this video, you can see you can better see the distribution of this decrease over the proximal femur, and you can see that all these decreases are located in the cortical shell. And it's similar. Here you have the results at month 18 for abaloperoxide, and here at month 18 for teriparatide. So, no, sorry, I will, no, yeah, okay. So to summarize, clinical studies have demonstrated that the trabecular volumetric density parameter and the cortical surface BMD parameter are associated with the presence of the prevalent and the incident fracture, osteoporotic fracture, for major osteoporotic fracture and hip fracture. We have also demonstrated that the trabecular volumetric density parameter exhibited the highest association with the prevalent fracture for both major osteoporotic fracture and hip fracture. And we are also demonstrated that this parameter, the trabecular volumetric density, is the strongest predictor of major osteoporotic fracture and hip fracture. And in the case of hip fracture, is significantly better than the aerial BMD, even after adjustment for common parameters such as age, BMI, or aerial BMD. Considering treatment monitoring, results observed in terms of aerial BMD in all the studies are those expected from the literature, with an increase in all treatment groups. The 3D analysis reveals differential effects at the cortical and the trabecular levels, with increases of the trabecular density were observed under alendronate, zoledronic acid, and more pronounced under denosumab, or those under denosumab previously treated by biphosphonates. And we have also observed, you can see here the cortical results, that under denosumab, you have this huge increase of the cortical compartment that is quite similar to the one on the zoledronic acid. But on the teriparatide, we have observed no changes or a small decrease or a small increase in the case of the active trial, while a significant increase was observed on the abaloperoxide. When splitting this combined cortical parameter, we have observed that this increase of the cortical surface BMD under alendronate is driven by an increase of the density only, while with no changes of the cortical thickness, while under denosumab, for both denosumab or denosumab previously treated by the biphosphonate, this increase is driven by both an increase of the density and an increase of the thickness. Under teriparatide, we have observed more or less no changes in terms of surface BMD, and this no changes is linked to an increase of the thickness concomitant with no changes or a small increase of the cortical volumetric density. While under abaloperoxide, this increase is linked to both increase of density and thickness. And these results are in line with those obtained you can have in the QCT literature. So if you want to have access to these different studies we have done, you can go directly to our website, and you have to go to a journal paper window, publication window, and then you will be able to have access to all. You will be able also to make a search by topics. I don't know if you want to case control or fracture prediction or diabetes. You can check if clinical data exists or not. Thank you for your attention.
So that we now have opportunities for questions and answers. They should be typed into the question box on the side of your screen there. We have some questions already, and I will perhaps direct the first one to Ludo. And the question from Dan Hill with GE about internal rotation of the femur and how that might affect the modeling parameters. Has that been investigated with 3D-Shaper?
Okay, well, thanks for this question. That's a very interesting one. This is not something that we specifically investigated, but we should be actually less sensitive, let's say, than the 2D DEXA measurements, because the rotation is actually something that we take into account in our 2D to 3D registration process. So in this video, I show you the first thing that we adjust in our model is this rotation. So there are precision errors in our method, but if there wouldn't be any precision method, if you take two femurs, one with internal rotation and another one without, it should provide exactly the same results.
Okay, thank you very much, Ludo. And a related question also from Dan, asking whether 3D-Shaper has been used on different technologies, comparing the results, say, with a GE scanner and a Hologic scanner. Are there differences or similarities, or has that been done yet? Ludo?
Sorry, I thought this question was for Renaud. Sorry for that.
Well, I'm gonna.
Our measurements are standardized, so there is no significant difference between 3D-Shaper measurements when measured from GE devices or Hologic devices, because we have this standardization that is integrated in our software.
Okay, very good. Now we have a question for Renaud. I'm sorry, Renaud, you had a comment.
In terms of absolute value, we have this standardization, but for the precision in overall, we have more or less the same precision in Hologic and GE in terms of relationship with the QCT parameters.
Okay. So Renaud, question for you from Dr. Stier and from Mary Buchsien about different races, and have you data on looking at other than Caucasians or Spanish people? You've got some Japanese data, obviously. Yeah. Can you make a comment there?
It's a good question. It's a really good question. To date, we have in our 3D model, the average model we use from the population that we registered, we have only Caucasian people. So this is to date is one limitation of our methodology, is that we don't have included inside the model other ethnicities. What we have done recently is that we have used our Caucasian model on Japanese people, and in Japan they have a really specific femur shape and density. It's really different from others, because they have a really step angle of the neck, and we have good results. In the future, we want to include new ethnicity in our model. It's ongoing, so we will include ethnicities, but it's not so. In Europe, it's more difficult to have access, just because we have less people from QCT from Asian people or from African American, which is really it's much more easy in the United States, for instance, to have this panel of different ethnicities available. But we are working on that, because it's a clear limitation, and we know by the studies done that differences exist between people from Asia and people from Africa, or African American, or Caucasian, or whites, or Hispanic. They are different.
Okay. Okay, very good. Another question from Mary Buchsien. She asks, from the fracture studies, have you evaluated sensitivity and specificity compared with aerial bone density, the ROC curves? You showed a little bit of the data there, but can you comment, Renaud?
Yes, we have done that. I don't have the figure in mind. I can send the figures to Murray books. I don't have that in mind.
Okay.
But we have done that. Yeah.
Okay. Another clinical question, I guess in different disease states, say post-polio, multiple sclerosis, there may be particular changes in patient groups. So the question from Dr. Rivora is, do you have experience in patients with multiple sclerosis? And maybe we'll broaden that a little bit to look at different disease states and which disease states you do have data on and which ones may be of interest to look at with this technology.
Okay. On this specific pathology, we don't have. Okay, because we we have not enough time to perform all the to work on all these secondary osteoporosis diseases. It's an open field. We have done some studies on glucocorticoid effects and also on people suffering from polio. But it's really it's like few, so I don't have a really good answer. We have done some in acromegalic subjects. We have two studies, one comparing subjects with and without acromegalia, and we have also analyzed the activity of the disease, the severity of the disease, and the association with the fracture, and we have observed that with the cortical density, in this case, the cortical density parameter can predict or is associated with the presence of the fracture, which is not the case for the density, the areal BMD, or for TBS. And we have just finished the follow-up of this cohort. We have 2 years follow-up, and again we have quite interesting results depending on subjects that switch from active to control disease. And we have observed these changes. We have observed specific patterns in terms of changes inside the two compartments. Otherwise, we have almost nothing. So feel free to investigate. No?
So again, as been mentioned, the value of a technology where you can look back at prior captures of DXA scans is you can do the prospective work if you identify a patient population looking backwards in time.
Exactly.
So a question for Ludo, which I don't entirely understand, but I'm sure you will. In a 3D constructed model, are the areal bone densities of the adjacent pixels through direction perpendicular to the coronal plane different? You understand what the question is?
I'm not sure I'm getting it either.
So just looking at adjacent pixels on the analysis, are they oriented in the same direction? Perhaps that's the sense.
Oh, okay. Okay, I think I understand. That's okay. That's because we have a 3D model and the 2D image. So maybe the question is, are we less accurate in what we are reconstructing in that direction, perpendicular to the image, compared to that direction? Surprisingly, we're not, because in this validation that we've been doing against CT, the errors that we found was very similar in the lateral or medial aspect of the bone compared to the frontal or to the anterior or posterior aspect of the bone. I would say that in a femur, in the bone, everything is kind of correlated. So if you have a high cortical bone at the medial and lateral aspects, you would also find high cortical bone density, for example, in the anterior or posterior part. So that's why the accuracy of our model, I would say, is kind of similar in the 3 dimensions, I would say.
Okay, we have a clinical question from Dr. Mesgrinaha, and the question for Renaud is, can you let us know what are the most important 3D-Shaper parameters to be used in clinical studies and in clinical routine? Which ones would you focus on, and in particular, those that predict femoral neck and vertebral fractures best?
Okay. It's not easy because depending on the if it's just for fracture, I would say the trabecular volumetric density for just for the fracture. If we talk about overall disease, I would say all, because you have depending on the disease, if you have subjects with CKD, you can have this opposite effect on the cortical and the trabecular compartment. It's the same. You can have this strange also effect on the cerebral side, for instance. So I would say depending on the disease or what you want to catch, you need to select the parameters. Usually, what I do when I make an analysis is that I start with the overall femur, using only values, using the trabecular volumetric density and the cortical surface BMD parameter. I have a first idea of what's going on. Then I split the cortical surface parameter in cortical thickness and density. And then I go directly to the 3D mapping. And with that, you can have a better idea of if you have a global effect or a local one. And if you have a local one, you can split your femur or select a specific region of interest to investigate further, as we have done in the active cohort analysis. We have done this overall values, considering only average values. Then we go to mapping. Then we go to slices. Then we go to regions exhibiting decreases only. For the clinical use, our approach was to simplify the use of our tool, selecting only two parameters with the limitations of these two parameters. The cortical surface BMD, because in one parameter you can have an kind of a surrogate of the strength of your cortical compartment, because in one parameter you have the thickness and the density and the trabecular volumetric density at the total region of interest. But we have few now we have few experience on the use in clinical routine. We are more now we are more focused on research application, because we need to start by that and go to clinical application. But the idea is to simplify at the maximum the number of parameters, because even in this case of we have only two, you can have an opposite effect. And in this case, how to interpret that? Okay, maybe the answer will be the results of the finite element analysis. To have only at the end only one parameter which deals with the overall strength of the femur, because you can have an increase of the trabecular density and no changes or a decrease of the cortical compartment. And in this case, it's difficult to know if the patient is at risk for fracture or not.
Yeah. Okay, very good. A question, a simple one for you, Ludo. Has 3D-Shaper been applied to children? Can you comment on pediatric applications or younger individuals?
Yeah, no, not yet. It's challenging because for two reasons mainly. The first one is because the bone is not completely formed yet. You have some cartilage in some part of the bone, and the second one is to have access to the data. We couldn't do the same. Well, it would be complicated to do the same approach as the one that we did for the adult population because of the CT scan and the radiation dose for children. So here, what we could do is to work with MR data and DEXA scans of children. No, we haven't done it yet, but that would be a very nice and a very interesting application for pediatric to better monitor the bone growth through the age. Yeah.
Yeah, and especially in pediatrics, to have a low radiation technology that may be more applicable to pediatrics.
Yeah,
so we're just at the top of the hour, Renaud.
Yeah,
go ahead.
Just to say that in terms of pediatric application, the only thing that we could think is to use the approach considering children at the end of the growth, when you have these the almost entire femur, the final shape, no, and density distribution. So I would say after 16, it's still children now. You could imagine use our approach, use 3D modeling, the 3D modeling to check, but it's research. I don't know if it works well or not, especially for the density distribution, because the density still continue to increase. No?
Yeah, that would be very interesting in elucidating the developmental aspects of the skeleton in pediatric patients. So we've just come to the top of the hour. We have a comment from Dr. Lucas Ricardo Brun that he has recently published an article on rheumatoid arthritis patients using 3D-Shaper. So I direct you to the 3D-Shaper website, and you can access the full library of articles and presentations that have been made with the technology. Any final comments, Ludo or Renaud?
Thank you.
Hearing none,
yeah.
I want to thank both of our presenters for very clear and comprehensive presentations on the technology and how it's been applied to date. Hopefully that's put some ideas in people's heads about directions that they could go with this very powerful technology to look at 3D modeling of DEXA scans, which are probably on your machine next door. Again, with thanks to all of our attendees for taking the time to attend the webinar, and inviting all of you to have a look at the 3D-Shaper website for some further information.
Yeah,
Thank you very much, everybody.
If they want to send questions, we will be happy to answer. So feel free to send an email.
Very good. Thank you again.
Thank you.
Bye.
Thank you, everybody.